¿Por qué estoy 2 veces? Ah, estoy. Hola. Hola, María.
Estaba moteada.
Sí.
Muy bien.
Bueno, estamos exactamente on time. A ver, ¿qué nos tenemos que hacer? Estoy medio oído.
Es viernes.
Es viernes. But it's not over.
Mi pregunta es, ¿puedo dar la presentación en inglés o en castellano? Ya lo hablamos, pero quería saber el público en general hoy, la mayoría.
La presentación igual queda grabada en YouTube. Hay público mezclado. Hay Corina Alhoff. No sé si ven. ¿Quién más? La mayoría.
Así ya queda.
La mayoría somos hispanohablantes, pero hay algunos no hablantes. Que yo sepa, por ahí hablan, pero no dicen nada.
Igual hablo inglés argentino,
Dale,
así
okay. Como todos nosotros, as all of us. So, María del Pilar Fernandez is here to talk about COVID-19 as a social
or vector-borne diseases.
Social complex socio-ecological system. Not COVID-19. I'm sorry. I thought it was COVID-19. So you are now, you were a postdoc in Columbia, I think, in university. And you are moving now to Washington, not the Washington State, that is in the very west of the US. So okay, let's start.
Okay, I'm gonna share my screen. Let me see, where is it?
Below, to the right.
Yeah, no, I can't find it. I have too many things open. Wait, I need to. Sorry. I'm gonna, close some stuff. So why is it not finding it? Listen up, sorry. It's obviously. I'm just gonna share my entire screen. This will be. Well, you can see my screen, right?
Yes.
And you can see the presentation.
Yes.
Okay.
I click hide in the thing in the below.
Oh, sorry. What? Hi, there you go.
That is better.
Okay. So yes, I'm María del Pilar Fernandez. I'm Argentinian. I'm gonna show a map to my trajectory in life just to present myself. I did my undergraduate master's, which is all together in Argentina, at the University of Buenos Aires, and I did my PhD also at the University of Buenos Aires, and I finished in 2017. And then I got awarded a fellowship from Columbia University at the Earth Institute to do my postdoc studies. And I was at Columbia University until September this year. And now I'm Washington State University, which is on the other side of the school, at Global Health Institute, Washington State University. So I'm an assistant professor now. I just started my own lab, but I'm very, very new. So in this presentation, I'm gonna talk to you a little bit about both the systems that I've been working on. I work on Chagas disease in Argentina and tick-borne diseases in Eastern United States. And so I'm gonna present both of them, what's the problem, and what's the approach I have taken, first for Chagas disease and then for Lyme disease, as an example of how the systems can we understand them as complex systems, and also including, because both of them are diseases that affect human, how we can think about them as socio-ecological systems. My training is as an ecologist. I'm mostly a population ecologist by training, but I always work in this interface between ecology and epidemiology. So just to do a quick overview about both systems, there are some similarities, but other things are very, very different, particularly when we think about it, when we add the social component to it. So Chagas disease is vector-borne disease, that it's mostly transmitted by blood-sucking insects that are called triatomites, and several species of them. But there's also vertical transmission, so if the mother is infected, it can pass it on to the child. And then it's mostly affecting Latin American countries, from northern USA, so northern Argentina to southern USA. And across this geographic range, there are different species with different ecology, different species of triatomites with different ecologies that really affect the system that we're studying. It's considered a disease of poverty, a neglected tropical disease, and human is one of the main hosts. So the humans actively participate in the transmission cycle because they can infect the triatomites, and then they can continue the cycle this way. Lyme disease, on the other hand, well, it's also a vector-borne disease. It has a different distribution. It's a holarctic distribution, mostly in North America, Europe, and Asia. It's usually thought as a disease of the rich, so it's completely opposite to Chagas disease. It happens in the more affluent areas where people have more resources, but we still have this question. And when I arrived, especially having worked on a disease of poverty and coming to the US and started working on this disease, it's like, well, here there are health inequalities in the US that are really important. And that this is something that it's really unexplored. What if the social inequalities of Lyme disease? And humans are, in this case, incidental hosts. So we can think about as dead end, not only for the bacteria that causes Lyme disease, but also for the tick, because humans are gonna find them, or the ticks are gonna drop in an environment. After they finish feeding, they're gonna drop in an environment where they cannot continue their life cycle. About the disease a little bit quickly, Chagas disease is caused by a Trypanosoma cruzi, which is a parasite. As I mentioned, it can be transmitted by triatoma bugs, vertical transmission, and there are other secondary routes of transmission that are not really that important. The human disease usually goes, it's what we call a silent disease because it has an acute phase with not very obvious symptoms, and then it goes into a chronic phase. And a third of the people might develop heart or bowel problems, and it's estimated that it has a 10% mortality. As I mentioned, it happens across Latin America, but the most most of the vector-borne transmission occurs in the Gran Chaco region, which is this green region highlighted here on the map. And the main vector here is Triatom infestans, which is this insect here. And it includes humans, dogs, domestic animals like dog, cats. They also feed on chicken, and they might feed on other vertebrates that might be available. And during the day, they seek refuge in people's houses. So if the house is very precarious and it has a lot of cracks in the walls, this bugs are gonna, that's where they establish their colonies. When we talk about Lyme disease, in the US, there are several tick species that can transmit different diseases. The main ones are here, which these are the first two are the black-legged ticks, Ixodes scapularis. You have the adult females and nymphs, and they can transmit not only Lyme disease, but also several other diseases that range from parasites to viruses. The dog ticks also can transmit other diseases, and then we have the lone star tick that it's invading. It's a tick from the south, and it's invading north very quickly. So here I'm going to concentrate just on Ixodes scapularis, and just to give a quick overview of the life cycle. The eggs emerge in the spring. In the summer, we have the larvae emerging, and they feed on hosts, mostly birds and small mammals. And then they overwinter, so they go dormant over the winter, and they emerge the following spring. They molt into nymphs. They seek for another host to feed on. There can be a wider range of animals, including humans. And then they molt into adults in the fall. And then they feed again. They mostly use big mammals for the adults, look for big mammals for the blood meal. And once the female gets a blood meal, they lay eggs the following spring. So it's a really 2-year cycle, and it's very long. Deer are really important hosts because they can transport the ticks long distances, and they are the main host that provides the blood meal for mostly adults, but they can provide blood meals for all other stages. But they don't get infected with the bacteria that causes Lyme disease. Small mammals, on the contrary, are the ones that provide the blood meal to the immature stages of the ticks, so nymphs and larvae mostly, and they are the ones that are the main reservoir for the bacteria. But their competence as host of the ability to transmit the bacteria to the ticks really varies between species. The main one is the white-footed mice. And here, as I mentioned, humans are the non-host. They can get any of the life stages, but they're not going to transmit the bacteria back to the tick. Also, the ticks feed once per stage. Mostly, it's very rare that they can get 2 blood meals, and they get the infection through the blood meal. So when they emerge from eggs, they're not infected. So why do we need to think about a systemic approach to study these diseases? Most of the things that I've mentioned are mostly ecological factors and biological factors that affect transmission. But when we think about the human disease, we also have the socioeconomical factors that play a big role in the transmission of the diseases, not only for the exposure of people to the vectors, but also how the conditions might favor the vector populations as well. And we also have, you can take it into a higher hierarchy and think about cultural and political factors that might be also affecting, for example, public health policies or vector control programs that can affect transmission. And these are different, what we call different dimensions that not only, they don't affect, I mean, they all affect transmission, but they also interrelated. So socioeconomic factors can affect ecological factors as well. So we need to think, how are these different dimensions interrelated and ultimately related to the transmission? So when we think about complex adaptive systems, we have all these hallmarks here, and most of them would apply to when we think about transmission. I'm particularly interested on emerging properties, and although it's really important to study these dimensions separately, We know that just adding the effects of all of this together not necessarily will explain transmission, but rather the interrelationship and how the building blocks are related to each other, that it's going to determine emerging properties. But I'm also really interested about the feedbacks, how people adapt to changing conditions that might determine, so for example, their past exposure might affect how they protect themselves and future exposure to the vector. But that might fade off with time, so we get the cycles. And those are kind of things that I'm really interested in studying. And why is this also important? And if we think about, for example, Chagas disease, we have events, which could be, okay, we have houses infested with the triatomine. So we can go and do firefighting tasks, such as spraying just the houses. But if we keep doing this and we don't understand what's the trend over time, then we're not going to understand how and why and where is reinfestation happening. So we can, if we learn these trends and patterns, we can anticipate. So we can plan for vector control actions that are more cost effective, and instead of always arriving late to the infestations. But we can go a little bit deeper and trying to understand what are these relationships and how are the different variables related, so we can even plan and design better interventions and also anticipate any unwanted consequences or unintended consequences of our and basically our design on vector control. So just this is for my Chagas work. This is work that I did at the Laboratory of Ecoepidemiology at the University of Buenos Aires with Ricardo Utler. All these people were involved, and the researcher Sol Gaspe was, we worked side by side on the field. So this is work that I did for my PhD, and why this is important to control Chagas disease in endemic areas, not only for the people that are living there, but because it has implications through migration and other areas in the world, and it has become a worldwide problem. But still, vector-borne transmission in endemic areas is what's driving most of Chagas disease patterns that we see worldwide. And 60% of infected people live in the Gran Chaco region. So this is where we concentrated. And there has been some large elimination efforts through the years. I'm not going to go into details, but during the 1990s, there was this Southern Cone Initiative that basically reduced a historical distribution of Triatoma infestum, which is on A, the figure this, to what we see now, which is B, which is mostly restricted, but it also mostly happens in the Gran Chaco region for several reasons. And we have a lot of challenges here. There are political and economic instabilities in the region. There's scarce resources available towards control. There are other priorities too, like mosquito-borne diseases, and this year, for example, COVID-19. We have the punishment of success because this Southern Cone Initiative was successful. There is less political interest to reduce transmission where we haven't been able to achieve control. There's also highly focal distribution and hidden hotspots because it mostly affects vulnerable populations that have not easy access. And there's also a new thing that we've been finding some regions where it's insecticide resistance, and there's also salviatic falci that we need to understand where they're happening. So this is, when I was doing my PhD, I was mostly trying to understand what were the ecological and social determinants of human infection. So I designed this household network, which implies all the from previous literature search and things that we knew how the system worked. And so I created this, which is a huge hypothesis of how the system works. I'm not going to go into details about it, but you can see here it's more ecological factors, and this is the more social determinants of health. So things related to the socioeconomic position, affecting the demography at a household level, how people move, how they access healthcare, etc. So as a area of study, I chose here in the Gran Chaco region. We work in Pampa del Indio in Chaco, in different rural communities. For this one, I concentrated here, what we call Area 3. We divided the whole municipality into 4 areas, just for logistic reasons. And Area 3 is mostly Kom native territory, which most of the people there, 90% of the people are Kom people, and the remaining people are Creole people. So what is interesting about the history of this place is that most Kom people used to be nomads with semi-permanent campsites. So they move around a lot, and because they move around a lot, they didn't allow the vectors to establish in their houses, which they could look something like this. Because the vector takes it develops slowly. It's not like a mosquito, like in a week you go from a larva to an adult mosquito. Here the whole life cycle can take at least 6 months or more. So they didn't give the vector enough time to develop colonies in their houses, and so they didn't really have Chagas disease as a big problem. But with the first Creole settlements in the area, this changed, and they were basically forced into more sedentary settling pattern, and the houses continue being really precarious. But now, because they didn't move as much, the vectors were able to achieve greater densities, and now around this time, that's when Chagas disease started affecting. Also, there was a lot of deforestation in the area, so that forced the sylvatic triatomine populations to adapt to these new changing conditions. And still during the 90s and right now, you can find that this area is still precarious, but there's a lot of heterogeneity. Most of the houses are mud houses with tin roofs, and then you have the government has made this new plans for residencies, but it's very limited. And so what we did is we went in October 2008, we did a baseline study where we visited all the houses in the area, looked for the triatomines, and then we did a community-wide spray. And then we did yearly visits to check for triatomines, and we sprayed any house that was infested. And in November 2012, I started my PhD in 2012. And this is when this year we have less than 1% of house infestation, so we decided to go ahead and do diagnosis and treatment in the field. I went for 2 years, and we diagnosed and treat 80% of the population there. So we work with the communities, explain what the project was about, get informed consents and extracted blood, and conducted the diagnosis with the local hospital. And we found that 25% of the people were infected. But this is obviously changes with time, and because this is a chronic disease that unless you get a treatment, you don't clear the infection, then you can see this cumulative seroprevalence over time. One of the first things I wanted to see if it was the intensity of transmission was constant over time, which you would find if there were no changes conditions to exposure to the vector. And I took a catalytic model as a null model to compare our observed curve to what we'd expect if the course of infection was constant. And not surprisingly, it wasn't. And here I mark all the interventions that have been done in the area to control the vector. So we know that this have different impacts, and that's something we are studying now, and what are the relative impacts of each of these interventions. Going back to the human infection, one of the main questions that I wanted to answer is how the ecological and social factors interact to determine human infection as this complex system. The first challenge we have is how do we measure socioeconomic status in these settings where there is a structural poverty? We couldn't use any income or anything like that. So I went back to literature and worked with economists to develop new indices using multiple corresponding analysis from the data derived from the surveys that we conducted in the field. So I conducted two socioeconomic index, the social vulnerability index that take into account the housing construction material, demographic variables, such as education, and if they have any type of monetary income, but measure as welfare, informal work, or any type of formal work. And then the asset index, which is just what they had. And this is published in this paper, but basically we're thinking, and I'm going to go really quickly over the framework. This is a framework of the social determinants of health, where basically we have structural determinants at a household level, for example, that is determined by a hierarchy, which is a socio-economic and political context that will determine the intermediary determinants, the material circumstances, that will affect health outcome and might affect the political and socioeconomic context as well. So it can also, through culture, can affect behavior. And for example, one of them is access to healthcare. So not surprisingly, the social vulnerability and the asset index were inverse relationships. So we use the social vulnerability as a measure, a more comprehensive measure of the socioeconomic status of the families in the area. And we found that it changed with mobility pattern. So people that didn't move a lot, that they live in the same house through the study period and had a social lower vulnerability than those that were moving into different houses, or they were going to other places outside the study area. And so the first thing, now that we have a measure that can account for the social determinants, we look at how is the social vulnerability related to the ecological factors. The first thing we explore is how is it available to host ability for the vector. So all the vectors that can affect, that can provide a blood meal for the triatomine. And we saw no relationship. And this next thing we wanted to explore is how the relative blood meal proportions that the vectors were taking from the different hosts were affecting could affect the human feeding rate. So from this previous study, we knew that the proportion of blood meals that the triatomines took on dogs and poultry would decrease the feeding rate on humans. So they would feed less often on humans, and thus they will have less impact on transmission. And the dogs are important because they are really highly infectious. The parasitemia is really high. So the probability that a triatomine is going to get infected when they feed on dogs, it's really high. And for chickens, they don't get the infection from chickens, but they can achieve really, really high vector densities when they start feeding on poultry, because it's a very stable feeding source. So with the triatomines collected, followed by dogs and then chickens. And you can see here that there's a lot of mixed blood meals. But the most interesting thing that we found is that the dog vector contact increased with social vulnerability. But this effect, it only increases with social, a lower vector abundance. So if the vector abundance was high, there's really no difference on dog vector contact rates. But when it was low, they actually, if they have lower densities of the vector, the social vulnerability will have a great impact on how often they would feed. So we can think it another way, and this is about the complex interactions between social vulnerability and the ecological factors between dogs and triatomines. So if you think about the low social vulnerability over here, you can see a strong relationship between vector abundance and the blood meals that they take on dogs. And if we think about the relationship we had before, that would mean that you have lower infection rates on humans. Now, what would happen here is at high social vulnerabilities. Basically, it was kind of independent. The vector density was independent of the blood meal, so it was really high and high social vulnerabilities, but it really didn't depend if whether you have low or high vector abundance. And we don't know about this relationship. We would expect that they would have lower feeding rates on humans, but this is also dependent on vector densities. So this is a little bit more complicated when we go into high social vulnerability. The next thing we wanted to see is, we know that the human infection is related to infected vector abundance. And so we wanted to see how it was related to host availability and the social vulnerability, which we knew we were independent. We saw no interaction, but it increased both with host availability and with social vulnerability. This is where we saw most of the infected vectors. And so we went into how the ecological and social factors interact to determine human infection. And this is published here in this paper. So taking all the demographic factors, some ecological factors in green, the infected vector abundance, host availability, and some social variables like social vulnerability and mobility. Mobility is how much people move between houses, or that if they tear down and build another house within the study area. So with this model, for the total population, we knew that it increased with age, that home people were more susceptible to infection, they were more at risk, and it increased with infected vector abundance, which was not surprising. It increased with social vulnerability. It decreased with host availability because that divert effect between dogs and humans. When we adjusted for infected humans co-inhabitants. And we repeated this for children because we know that the vector conditions where we measure them are more related to the children's infection, because adults' infection could have happened a long time ago. So here we saw the same thing. Ethnicity was not significant anymore, but that's because mostly all infected children were con children. So it really wasn't, we didn't have girl children that were infected. I think only one. Again, it was related to infected vector abundance. The social vulnerability, it's kind of the same situation we found with ethnicity. Most of the children came from the most social vulnerable families, so we didn't have enough variability to measure that. But it was most interesting here is that the mobility, we analyzed whether people, I'm going to call mover children the children that move between houses within the starry period, and the other non-movers are the ones that live in the same house through the starry period. And we found no effect. But then we have to think about the interactions what we were looking for and how the variables are interrelated to each other. So the social vulnerability and the infected vector abundance had a negative relationship, meaning that if at the same, so if they have the same vector abundance, the infected vector abundance, then those that had, so if they have the risk of infection for houses with low vector abundance but high social vulnerability was similar to the probability of infection of people that live in households with low social vulnerability but high vector abundance. With the mobility, we found the same thing, and in this graph, it's easier to see. So the difference between non-mover children living on infested domiciles and non-infested domiciles is this huge gap between the black line and the gray line. So they were a higher significant risk. Among non-mover, like children that move through the study period, we found a difference between infested and non-infested domiciles at baseline. And this is because they could have gone exposed somewhere else. So mover children may have had contacts on other places other than the house or the original house, and this is higher implications for vector control. Because we assume that people got infected in their house and not necessarily through, or if they change houses all the time, it's really hard to keep track of that. So with this information, we built this risk maps to detect priority areas for case detection and design better control strategies. For some take-home messages, the focal distributions can be explained by the social determinants of health, and there's a dual role of domestic animals that it's not straightforward, and there's a lot of trade-offs. And we can use this risk maps for control. The other important thing is that there is this trade-off between mobility and human exposure that it's worth investigating more, and that's one of the things that I'm going to start looking more in the coming years. And for Lyme disease, I work at Columbia University with Maria Diop-Wasser. She was my PI. And Maeve Van Acker is a PhD student that is doing significant work for this project. We got recently awarded an NSF grant. So this is ongoing work that is going to go on for 2 more years. So this has been an expansion, a geographic expansion of Lyme disease between 2000 and 2017, and you can see this maps. This is mostly the Northeast United States, and this is the Midwest. But also within long endemic areas, there has been an expansion into urban areas. So this is, for example, this is New York City, the different boroughs. This is the Staten Island, the least famous borough of New York City. But here in particular, this has been an increase on tick-borne diseases, particularly Lyme disease, over the last couple of years. And most of the ticks are, this is from a study we did in 2017 when I first arrived. We went to look for ticks in the different parks, and basically the problem was mostly here on Staten Island. So we can think about one of the long questions I have been here on the Lyme disease work is like, what more ticks does it mean more cases? And this is a very important question because there have been a lot of studies where they try to control the tick populations, particularly in people's yards, because people can get exposed when they go to parks, but also if ticks get to the yard. So there have been interventions where they were really successful in reducing the number of ticks, but they saw no difference on the number of cases. And it's really this relationship, it's non-linear, and thus it's a little bit more complicated than, okay, we have more ticks, then we have more cases. And we can think about it different ways. So the density of infected nymphs, we'll call it the hazard, is what people will get exposed to. And this will depend on the host availability, so which animals are available, which will depend on the host community and the host movement and behavior of the different environments, but also will depend on abiotic factors, mostly at the microhabitat level. But when we include the human dimension, then we know that Lyme disease risk is actually interaction between human exposure and the density of infected nymphs. We can add other layers of complexity about, like, once they get exposed, if they can have access to healthcare to get diagnosis and treatment, but that's a different thing. So let's say they got infected as a measure, and the human exposure will depend on human behavior, basically outdoor activity patterns and the protective behaviors that they decide to use. But it also can provide resources for the different wildlife and thus affect the density of infected nymphs in their environment. And this is also, to add another layer of complexity, it depends a lot on the landscape configuration. So we can think about host movement patterns changing across the landscaping gradient, the landscape effects on the enzootic hazard, the host movement, effect on the enzootic hazard, where are humans getting exposed to ticks? And so this is something that it's very complex across the gradient. And for here, we're concentrated on urban areas and urban forests mostly. And you can read about what we recently published this paper about explaining how basically this figure the different mechanisms that will play a role into the equiepidemiology of tick-borne diseases and how they change across the landscape gradient. But going back to this figure and going back to the grant, so we took this and tried to study to formalize it into the coupled natural human system, which is another way to formalize socio-ecological systems. But it's basically dividing into what we call the human system, everything that is related to humans, everything that is related to the enzootic transmission cycle, and it gives a special attention to the coupling process, and which are these processes that are coupling both systems. And so with that, we came up with this system, and this is our, again, hypotheses. We have the exotic transmission cycle happening in the wild, and mostly happening in natural areas and parks, but also can happen in pre-domestic areas. And we, in urban areas in particular, we assume that there's a source-sink dynamic where the ticks are in the parks and they go into people's yards, mostly transported by different hosts, deer or small or medium-sized mammals. And this creates the tick hazard that people are going to get exposed to, and they're going to get exposed to depending on their activity patterns and if they use any protection measures. But as a result of this exposure, they also make decisions on interventions on the natural system and maybe investment choices on household level interventions. So they might decide to spray for ticks in their yard, against ticks in their yard, or support local level interventions. For example, on Staten Island, where we're working, they're doing deer vasectomies to control the deer population. And the sum of all the different type of agents and how they do it will lead to Lyme disease risk at a community level. And that's something we measure all the time, which is Lyme disease incidence. But this human tick contact rate, this is what is really hard to measure. So for the human system, I'm focusing here. We're studying both, but I'm focusing right now on the human system. We're trying to understand where and how ticks are getting exposed to, where people are getting exposed to the ticks. How does the knowledge perception of risk and the preventive practices affect tick encounters and how all this is related? And what preventive practices are people willing to accept and pay for? Here in the US, there's no vector control program for ticks, so it really depends on the individual. And to try to understand human exposure to ticks, we can think about past experience of ticks influencing how much people believe they're at risk, how much people know, and what they can do. And that will influence mostly preventative behaviors, but to some degree, it will affect outdoor activities. And we have some evidence of this from some surveys we have done here, where people, after getting Lyme disease or getting a tick, they decided to stop going to the parks altogether. So how are we studying human behavior, which is really, really hard? So we have two strategies. We're using a smartphone application just to measure for a week the activity pattern. So in the app, they'll have a very short survey where every day we ask what they did that day, if they did recreational activities, very domestic activities, if they used any preventive measures, and if they had any tick on themselves. But also we're doing, in some houses, we're visiting houses on Staten Island in particular, and we're measuring knowledge, attitudes, and practice. It's a very long, it's a half an hour survey, but we're doing just in some houses. So the tick app, you can actually download it the App Store. It's for Android and iPhones, and I think that other operational systems too. But basically it's a research app, so we have a consent form, everything is through the app, and we have a lot of features here. This is the daily log, is the one that we call the short surveys. We started at least with set 15, but then we realized that that's unrealistic, and people will comply for a week, but more than a week they'll drop off. So we decided to just keep for a week and get the weekly pattern. And then just to turn it into something that people will get something back. So if they found a tick, they take a picture, they submit it to us, we identify it and give the answer back to them, and we have other resources for them. And this is some paper that we published with some more information about the app. And one of the first we wanted to do is like, okay, who's using the app, to see how we were biasing the information. And we saw like demographic wise was okay, it was really representative, but it was towards most outdoorsy people. So this last year we offer a few economic incentives, basically a gift card, so we'll get a wider representation. And this was useful because we deployed it pretty much anywhere in the US, and we were able to get information from different regions, so we can explore some behavior and residential risk factors between the Northeast and the Midwest. Regions that are very different. I'm not going to go into many details, but we have people in the Midwest who are more outdoorsy than people in the Northeast, and the people in the Midwest also use more preventative measures compared to the Northeast. And their interventions that they did to prevent their host visiting their yards was very different as well. And because we are also, if the user allows us to, we collect GPS information, we can, using underlying land cover classification, we can estimate the amount of time spent in different land cover types. Particularly, we're interested in forest because that's where the ticks are. And we're related to time spent in forest was actually associated with tick exposure in both regions. And this is self-reported tick exposure. And because we deployed this app in 2019, we have 2 seasons to compare between 2019 and this year, and we were able to see if there were any changes in outdoor activity patterns due to COVID. And in fact, we did. You can see the green, so the red line is the total outdoor activity patterns. We saw that they actually increase in 2020 compared to the previous year. And you can see here the recreational and outdoor activities, the pre-domestic activities were kind of on par, but they shifted here in 2020. People started doing more pre-domestic activities in their yard and going less to parks or to recreational areas in green spaces. The pink line is basically where the first statewide stay-at-home orders became effective. And I'm going to go really quickly through it, but just to, as an area of study, we're using Staten Island here in New York City. And we are selecting ecological neighborhoods, which because of this, we think that there is sort of sync dynamic. Then we have the parks acting as sources. And so from the parks, selected parks here in pink, we selected neighborhoods around it. And this is the houses we visit in red. We conducted tick drugs, basically to collect ticks that are outside, and did interviews. We sampled 130 houses each year. And we found like a third of the house had at least one tick, but we have different species. And we measure the human behavioral responses to risk perception, and we can divide it into avoidance or personal protective measures. We call it adaptive behaviors or risk mitigation, where they do interventions to reduce tick densities. So for the adaptive behaviors, as I mentioned, a lot of people avoided risk areas, so they avoided going to parks or forests. And then from the ones that actually use personal protective measures, most of them inform using adjust clothing to minimize risk, which is wearing long pants and socks. It's as simple as that. Not many people use other, so for example, there are tick repellents and not many people use them. We're just going quickly over this, but this is the framework we're working on to try to understand how these things that we measure in the survey, tick identification, if they knew about the disease and transmission role and humans, we're trying to build a knowledge score. And we also have questions about risk perception, so understanding this relationship between both the social influence. We have questions about the social network and how this affects the activity patterns and personal protective measures that we use, we measure in the app and in the more extensive survey, and how this in turn affect the tick density that they're exposed to. So we're using some techniques derived from the social sciences to build this knowledge score, for example, using item response theory. So it's combining a lot of techniques from different fields. And to measure, this is true, we're going to try to understand different pieces from different parts of the study. And then we're summarize everything in a Lyme disease an agent-based model to measure Lyme disease risk at a community level as an emerging property of the system. So I did a preliminary agent-based model where that it's very simple. These are the agents that move randomly. This is the blue square is the park. The rest of the urban matrix, and the red squares are houses with ticks. So if they had ticks in their yard. And I assign a probability if the area was risky of 0.03. Basically, I let them move. I run it for 90 days, which is the period of exposure during the summer. That's when ticks are active. And I measure different the effect of different adaptive behaviors on the tick on the human tick exposure. We cannot measure directly, but we can use the agent-based model to estimate what that would be. So just taking the no adaptive behavior as the null model, then we found that avoiding the park had the lowest, so it would decrease the human tick exposure most compared to using personal protective measures or spraying yard against ticks. But we think it's a combination of this. So this is very simplistic, and we're going to make it that derived from the information we have from Staten Island. It's like, okay, what happens if this proportion of people do this proportion of people do that, etc. The other thing we were interested in is into looking into how the landscape configuration affected this human tick contact rates without assuming any effects of the landscape on the enzootic transmission cycle, which it also does. And so I constructed this artificial environments with different habitat occupancy, so forest cover, and percolation probability as a measure of fragmentation. So more percolation probability means that the forest patches are more aggregated, and thus they're less fragmented. So these are some examples of the different scenarios, and then I use a generalized additive model to see the relationship between these variables. So we saw that percolation or fragmentation had a non-linear relationship, while the area did. So the more forest, it also always increased the number of ticks. And this is the relationship between percolation. So if we move here, we have more fragmentation, less fragmentation. And at this level, we saw the highest human tick contact rates. So then we look at the interaction between both. And we found that the human tick contact rates increased with forest covers, but it was non-linear at low percolation and high percolation levels. So at, if they're less fragmented. And basically, it's human tick contact rates increase both with forest cover and with fragmentation. In this direction, more fragmentation is here, but the effect of the forest cover decreased if it was less fragmented. So if we have large forest patches, human tick contact rates were actually lower. It was a protective thing for humans. So the future directions for this is to integrate the data from the field into the AVM, analyze the activity and mobility patterns derived from the tick up, and also include it as if values for the agents, and then assess the feedback between the natural and human system using this agent-based model, and simulate different integrated pest management interventions against ticks. And this is an example of the data we got from the app, where we have, this is one person moving through the environment, these are their trajectories, and you can see the person one, which is the yellow one, actually move very little and spend most of the time in the built environment, while person two spends some significant time in the forest and move a lot more through the area. So with that, sorry, I went a little bit over that, but that's, I think, everything. So thank you.
So many thanks. We have time for one question. If there any questions or
And how do I stop sharing?
we stop sharing.
Oh, I found it. Okay.
And yeah, I had some questions, but in the middle I forgot.
Yeah, I know it's a lot. So if you have any other questions in the future, you can send me an email. Me puede mandar en castellano.
Yeah, I was thinking about this very general framework about nature contact with people and diseases. So the idea that if you destroy nature, the diseases is like they attack humanity because we are destroying nature. Something that, but not like that, but I don't know if this framework could be applied.
Yeah. So we are in a way, because here Lyme disease in particular, and that's something I didn't measure, but fragmentation, it's mostly produced by humans in the human activity, will not only affect human exposure, that's what I was measuring there, but the next step is to measure how it affects the enzootic transmission cycle, because we know it will affect how the non-human host, so how the deer and the other mammals move through the environment. And they would increase, so there's some studies that show that at the edge of the forest, so if you have more fragmentation, you have more edge, and then you have more white-footed mice, which is the reservoir. And so you would expect more fragmentation, you would expect more tick hazards, or a higher density of infected nymphs. So that on top of, and we saw with the human movement, and in a very simple model, that humans will get more, if the fragmentation is higher, then they will have higher human contact rates. So if we combine the both, it's kind of a synergistic effect. So yeah, and these are things that you can see effects for human exposure, but also indirect effects of humans into the enzootic cycle.
Yeah, well, I was thinking about if that it is like more like linear thing or non-linear thing. But that's
yeah.
that is another thing.
Yeah, I don't think it's linear. Well, we can think linear.
Linear in the sense that more fragmentation, more exposure.
Well, there is a limit, because if you get super fragmented habitats, you stop having any. Those habitats are not going to support the population. So, for example, deer population deer are essential for the life cycle of the tick, and they need a certain number of like habitat to live in. And so if you get to extreme fragmentations, then you're not gonna have any host anymore. And so you're not gonna have any ticks or transmission. So it's in that intermediate fragmentation level where we're trying to understand the relationship.
Okay. Well, if there is no any comments, many thanks, Pilar.
Gracias.
Next and last talk by Juan Rocha in 5 minutes. So I need 5 minutes. Will be 35. We are 5 minutes. Give me 5 minutes. Okay. We have a small interval.